objectives of today's talk. And then we will go through, we'll start with emergency medicine, and then we'll go through POCUS in the ICU. We'll talk about sports medicine, and then we'll talk briefly about some evidence and upcoming research in the hospitals and general outpatient departments, and then what is happening at Phoenix Children's and how people at Phoenix Children's can get involved. So first, we'll go through the introductions. There we go. So Dr. Willyerd is from the ICU. He will be talking about POCUS in the PICU. He went to medical school at Creighton in Omaha, and then did categorical peds here at Phoenix Children's. He left for a fellowship to Pittsburgh, and then we were able to bring him back for an attending in the ICU. He loves POCUS, loves all things ultrasound. He's a member of the POCUS, or the Pediatric Research Collaborative on Critical Ultrasound. And a fun fact is that in July, it will be his 10-year attending anniversary, which is exciting. So looking forward, we'll see. Dr. Furmick with emergency medicine she joined the faculty recently. She was went to Midwestern here in the Valley, and then did pediatric residency at U of A. She did PEM fellowship, finished up here at Phoenix Children's in 2021. And then she went over and did the POCUS fellowship over at Valleywise last year, and then joined the PEM department and is currently the POCUS director. So I'm excited to hear from her. And then Dr. Paul is a non-surgical sports physician specializing in sports-related injuries, concussion, and fracture management. He went to medical school and residency at Vanderbilt, and then stayed on and did a chief resident year at Vanderbilt, followed by a fellowship in sports medicine at Cincinnati Children's. So his expertise in POCUS is centered around the musculoskeletal exam specifically, and then ultrasound guided procedures as well. My name is Clayton Long. I am one of the chief residents. I went to medical school at Iowa, and am just finishing up a chief year here at Phoenix Children's, and then next year I'll be starting HEMONC fellowship here at Phoenix Children's as well. My interest in POCUS, I'm a novice at POCUS, but I helped to create the curriculum at University of Iowa, and I've been interested in trying to bring POCUS, and I've been working with residents and working through the GME to try and get POCUS and increased education here at Phoenix Children's. And so I'm excited to talk about POCUS here, and the objectives of today's talk. One is to understand a little bit about just the capabilities in POCUS and pediatrics. And the other is to know the current research behind POCUS and the use in pediatrics. But most of all, one of the biggest things that I want to do through talking with a lot of different entities, we've had a lot of interest in there's a lot of individuals in different areas that are interested in point of care ultrasound, but we haven't combined them or connected everybody together. And so one of the goals is to have this presentation start a conversation and hopefully get people involved from residents to attendings, and then increase training and discussion throughout, so we can advance POCUS both here at Phoenix Children's and in the field in general. So first, we'll start with Dr. Furmick in the emergency department and an introduction to POCUS as well.
Yeah.
Yeah.
Okay, great. Okay, great. Well, thank you guys for having me. I'm super excited to be here. I'm hopeful that this talk, like he had mentioned, will stir up some interest and really start the conversation about how it can improve POCUS here at PCH, because we have lots of work to do. So what is POCUS? So point of care ultrasound is the use of ultrasound at the bedside by the clinician, and the images are obtained and subsequently interpreted in real time to directly affect our patient care, clinical decision-making, and then will often can be used, as Dr. Hall will go over, to guide procedures. So as you can see here, the actual machines have, and technology has improved quite a bit to where the patient used to sit in a bath full of water to complete an ultrasound, all the way to now this is something that can be plugged into your iPhone. And the real point of this slide is to demonstrate that the reach of ultrasound is much beyond what we think of in the clinical setting. This is now being done in rural areas. There are, medical missions, quote unquote, where they will go out, different groups, different POCUS groups will go out to rural areas or underdeveloped countries and show these clinicians how to use ultrasound. And given that these are relatively affordable, these are often their only modality in those situations where they have access to imaging. So it's also being done in the EMS situation as well to direct where patients go appropriately and more efficiently triage patients. So there's really an expanding scope of what this can be used for beyond what we classically think of as POCUS at the bedside in a clinical setting. The other great thing about this is it is a procedure and it's billable by CPT codes. They have their own CPT codes. So if done right, can be quite lucrative if, done appropriately. The next thing that I wanted to mention is this isn't meant most of the time to replace what is done by radiology. So I want to make that very clear. These are often focused limited ultrasounds that are done at the bedside to directly and immediately affect patient outcomes. So this is very different than a formal ultrasound that we send to radiology that gets interpreted. The formal ultrasounds are often much more detailed. These are things, and we'll talk about, these are images that are done. They're very specific indications, looking for very specific findings that we use. So ultrasound really started to take off in the 1990s in the adult emergency department. That's kind of the department that kind of paved the way as far as POCUS. And in 2001, the American College of Emergency Physicians, or ACEP, put together their first set of guidelines. I put the QR code to that here. This is a great resource for you if you're looking to start a program or even just want interest or want to learn more about POCUS. This document is over 60 pages long and has been revised multiple times, with the most recent one being in April of 2023. So this is a great resource. You do not have to be an ACEP member. They have tons of different documents on their website, anywhere from how to train your APPs to use ultrasound, how to code for ultrasound. This particular document goes over how to bill for it, what images should be included, what standardized training should be done, and how you can develop curriculums for either residents and or fellows. So like anything, we get most of our data from the adult population. So the peds tends to be a little bit behind the adults, but in 2015, AAP published their guidelines demonstrating that this is a recognized modality and should be practiced regularly in a safe fashion. So they published their guidelines in 2015, and now this is honestly a regular part of emergency medicine curriculum, PICU fellowship curriculum. It was on my boards as an ER doctor. So this is pretty standard now, and often part of medical school curriculum as well nowadays. So pretty integrated. Okay, so we're going to go over different uses of ultrasound, and everyone is going to have kind of how they use ultrasound differently. Being the ER doctor, I'm going to focus on the acute resuscitation and how ultrasound is used in those patients. So we're going to start with a case. This is an 11-year-old male who's involved in an NBC. He was unrestrained. He presents with a GCS of 14 and obviously hemodynamically unstable vital signs, right? His blood pressure is low. He's tachycardic. He rolls into the trauma bay. After your primary survey, on the secondary survey, you noticed large abdominal bruising there. And so something that can be done as part of our secondary survey is something called a FAST exam, or EFAST. So FAST stands for Focus Assessment with sonography and trauma, or the E portion is extended. And that's when you include one additional image that looks at the lung pleura. So this is focused on identifying free intraperitoneal or pericardial effusions or fluid. And it's indicated specifically, as we mentioned before, there's specific indications for these types of exams, and it's indicated in blunt and or penetrating abdominal or thoracic trauma. It's most often used in the patient that I just presented. So a patient with blunt abdominal trauma who's hemodynamically unstable. So these are a couple examples of normal FAST exams. So the FAST exam requires several different images that you obtain of the abdomen, and starting in the right-hand side of your screen is the right upper quadrant view, or what we call Morrison's pouch. So we're looking for free fluid. Free fluid will look hypoechoic or dark. And I'll show you a couple of images that are positive. But in this one, we're looking for fluid that accumulates in Morrison's pouch, which is the interface between the liver and the kidney. We also look, moving on from left to right, we look at the interface between the spleen and the diaphragm. We look at the heart as well, looking for pericardial effusions or any evidence of pericardial tamponade. We look at two different views of the bladder because fluid will accumulate around the bladder. And then this last image is the image of that I had mentioned of the extended portion. So this is where we put a linear probe at the clavicular line in a vertical fashion, and we look for lung sliding, and that if that is present, kind of this like motion kind of artifact that you see there, if that's present, then that is necessarily that's positive. Oh, thanks. Well, we have a little pointer. Oh, great. Okay. So this is what I'm talking about here. You can see that there's a little bit of motion artifact here, and that's the parenchyma, the lung sliding against each other. And when that's there, then you have no obvious, what's the word I'm looking for? What is it? Pneumothorax. Thank you. I'm like, I can't think of the word. Pneumothorax. Yeah, and then also, though it's not necessarily part of your FAST exam, you can, if you move your probe slightly more towards the patient's head, you can also see the base of the lungs as well. So if there is any traumatic blood there, any type of accumulation, you can see that as well, though that's not typically part of your FAST exam, but often can be seen if you have the correct patient setting. So this is your FAST exam. Here, this is what I was talking about with positive FAST exams. So you can see here, this is hypoechoic fluid accumulation. Now, one thing I want to point out is that fluid, whether it is ascites or blood, it looks the same on ultrasound. So you see fluid accumulation in this clinical setting, right? Our patient's hemodynamically unstable, had a traumatic injury. This can be assumed as blood, but keep in mind that fluid, whether blood or ascites, will look the same. And you can see it's a little more subtle here. These are both pictures of Morrison's pouch. You can see the interface between the kidney and the liver here. This is the tip of the liver, and this is accumulation of fluid. I should mention that all these images were taken off a really great compendium called the POCUS Atlas. I have the link to it down here. Anyone can submit images to this as long as they are de-identified appropriately. So this is a great collection. If you want to go on and look at normal anatomy, they often colorize the anatomy as well. So if you're trying to learn your anatomy and learn what you're looking at, it's a great resource to start with. So how does the FAST exam actually affect clinical decision-making? So these are the Western Trauma Association algorithm that I wanted to point out, and I want to bring your attention to this portion of it. So this is blunt abdominal trauma. Like I said, this very specific indications for a FAST exam in an unstable patient who has a FAST exam that's positive. If you have the ability to stabilize them, obviously your CT scan is going to give you more information. FAST exam isn't able to identify hollow viscous injury. It isn't able to identify that, actual whole organ injury or where the fluid's coming from. It can just tell you positive or negative, right? There's fluid or no fluid. So if you're able to stabilize your patient and get them to CT, that will give your surgeon a lot more information. However, if the patient is unstable and you have a positive fast and they continue to be unstable despite your resuscitation efforts, it can really expedite time to the operating room. And in that situation, laparotomy is indicated. And you can kind of follow that algorithm here: fast, positive, unstable, go straight to the OR and skip your CT scan. There is a role for repeating fast exams as well. And often in the pediatric population, we will repeat these fast exams multiple times to try to, a lot of times we admit these kids for observation who kind of have belly pain and lingering, but they're hemodynamically stable. You can repeat fast exams multiple times because we have, we have extra time with the kids. We often admit them. Okay, so let's talk about the data and knowing the limits. So this is adult data. So the POCUS Atlas also has something called the Evidence Atlas. So if you ever want to look up any of the evidence that is there, they have great synthesized tables, and that's what I took this from. The actual QR code is to the paper where this information came from. So if you want to read about that, you're welcome to. But essentially, this is a meta-analysis that was published in 2012, in which 22 studies were summarized. Roughly about 12,000 patients total were looked at, and demonstrated that they were looking specifically at adults with blunt abdominal trauma. They compared the FAST exam to one of 5 like gold standards, which included either laparotomy, CT, DPL, autopsy, or a clinical course. And essentially found that sensitivity is in the 70s and specificity is in, the high 90s. So what this means is, like I showed on that algorithm before, a positive FAST is very, very helpful. The pediatric data is a little less convincing. And this is mostly not, I don't think, any fault of the actual FAST exam itself, but just like anything, we have less pediatric patients. So this is a meta-analysis that only included 8 studies, roughly 2,000 patients, and compared to the gold standard of either laparotomy, CT, or observation. Like I said, we often admit these kids for observation and repeat fast exams. So you can see that the sensitivity varies quite a bit. Now, I will say that the actual upper limit of normal in most of these studies varied quite greatly. And this, I think, is important because at a lot of trauma centers, adult patients are 15, right? They treat anyone essentially over puberty that in the adult algorithm for trauma. So if you have in the same group an 18-year-old, that might greatly affect your data, right? So the specificity is pretty low, but the one thing I do want to point out is the specificity is really high. So just like the algorithm, if you have a positive FAST in the correct clinical situation where your patient is hemodynamically unstable, in that situation, FAST can be very helpful and ultimately totally affect clinical outcomes and management. Okay, so that was a FAST exam. We're going to go over another indication of ultrasound. So this was actually a patient that I had in February of this year in our pediatric emergency department. So this is a 5-year-old male, no past medical history, came in with 3 days of vomiting and diarrhea. Subsequently had 2 hours of respiratory distress. She had him seen at an urgent care. They said it was gastro. He's just worsening, so he came in. You can see he's tachycardic and tachypnic, satting well on room air. On exam, patient has a loud murmur. His heart is down. His EKG showed a QTC of over 500. So clinically, we're very concerned about cardiac, right? So something we can do at the bedside is something called a focused cardiac ultrasound. Now, again, this is not meant to replace what is done by a full echo by any means. This is a very limited cardiac exam that looks for pericardial effusion, tamponade, left ventricular function, ventricular equality. We'll kind of go over what that means. It looks at 4 views of the heart and the IVC. These are 4 examples of the images we obtain in a cardiac ultrasound. Again, moving from left to right, this is the parasternal long axis view, allows us to look at 4 chambers of the heart, parasternal short, here I have forgot. And then apical 4, and then our subxi view that we use in trauma as well. And we're able to look at ventricular. What I mean by equality is that roughly in this view, for example, your left side of your heart should be 2/3 the size of your right side of your heart. So in that situation, if you have something that's flipped and all of a sudden your right side of your heart is very, very large, then you can use that for your, clinical decision-making as well. Like, is something going on where the pulmonary pressures are much higher than they should be, right? That all of a sudden our right side has extremely high pressures. So in this particular patient, he actually had preserved cardiac function, but this is an example of how bedside cardiac ultrasound would be helpful. In this patient, for example, if you put a probe on your heart and you see this is a very glaringly obvious decreased cardiac function, right? So this is normal. You can see very good contractility here, and then this just kind of slowly squeezing here. This is an example of severely enlarged right side of your heart. So this is the right side of your heart, right ventricle, right atrium. So you can see this is much larger here. And that would be an example. This particular patient has COPD, so chronic long-standing pulmonary hypertension, right? In this situation, you can see the heart is much larger. So this is what I was talking about, ventricular equality. So if you have a patient who all of a sudden has a normal, healthy history, and you put a probe on and you see this, you might be concerned for something that increases your pulmonary pressures, like all of a sudden acute PE, right? So this can be very helpful in the clinical setting. This is an example of free fluid around the heart here. So, and this is actually tamponade here, because you can see the free wall of the right side of the heart kind of bowing in. So this fluid is causing clinical implications on this patient. Okay. Quickly, I want to talk about what's called a rush exam. So the rush exam is something that where we can use in the emergency setting, and we essentially combined the previous two modalities I just talked about. In addition, in the adult population, they also look at the aorta. In our pediatric population, looking at the aorta is important, but we often have less patients with aortic pathology, right? We don't have a ton of patients with aortic dissection as the cause of their undifferentiated hypotension. So the rush exam is indicated in patients with undifferentiated hypotension and or shock, and can help be used at the bedside to help decrease your actual differential diagnosis and help identify the etiology. Okay, so it looks at the heart, the IVC, the EFAST, as we talked about, in the aorta. This particular, there's a ton of data out there about how the rush exam is used. There was a good paper that was recently published in 2022, but this one was kind of the most famous one. So this is the one that I put up here. This QR code will bring you to it if you're interested. But in this situation, this was a randomized control trial that was published in 2004, and it randomized patients to non-traumatic, symptomatic patients in shock, and randomize them to either receiving a rush exam when they first arrived in the emergency department or after 15 minutes. In the situation of the patients who received the ultrasound in the initially upon arrival, that early group, the clinicians were able to narrow their differential diagnosis from 9 in the late group to 4. So greatly decrease their differential diagnosis, and were able to correctly identify the cause of the patient's shock within 15 minutes in 80% of the early rush group and 50% of the late rush group. So definitely is an example of how ultrasound can be used to affect your clinical decision-making and ultimately improve patient care.
Everybody. Oftentimes, in order to coax a critically ill patient back to homeostasis, physicians must employ invasive lines, drains, and tubes. That's why PICU patients look all tied up all the time. We're just trying to pull them back from the edge of disaster. Before the introduction of POCUS in the PICU, intensivists were trained exclusively to use anatomic landmarks for the placement of catheters. Sites were selected by visual inspection and palpation, and then you went at it. Most of the time, we were successful, around 87% according to research. Even the highly skilled couldn't anticipate certain things like anatomic variation, collateral vessels, thrombus, and that could be quite frequent in our repeat ICU patients or the chronically ill that come in frequently. Can't see the rest of my slides, which is awesome. Regardless, there was a good chance that when you're doing it blindly, you can, oh, there's a mouse. Look at this. Sorry. I didn't get the walkthrough. My bad. Also, there was a good chance that you would create a hematoma. Total rate in this Cochrane review of about 13%, or inadvertently enter the wrong vessel, like the aorta, 9% of the time. In critical care, we call that poor form. Then ultrasound entered the scene in the PICU around the time I entered fellowship. It allowed us to actually see into the vessels. With a little training and being able to directly visualize the vessel using POCUS, central venous access could be obtained more quickly, approximately 30 minutes faster than it used to be done. We had less complications. Those dropped to about 4% from 13%. We had less accidental arterial entry, decreasing 7% all the way down to 2.5% only. And we were much more successful at getting the line, 98% of the time versus the 87% I had mentioned. Our colleagues in adult critical care, adult pediatric emergency medicine, adult and pediatric surgery, adult and pediatric anesthesia, and neonatology looked at their success with POCUS and the data available and said, we should probably make this a standard of practice. Put them on our boards and, you know, have specific training requirements and documentation to show proficiency. I'm sad to report that PICU is still the odd one out. We have yet to add this crucial element to our certification requirements. With that said, let me show you the many ways that pediatric intensivists use ultrasound in their daily practice and how it can be used to enhance care. First is the use of POCUS for venous access of all types. On some of the slides, you'll notice the QR code. That was her idea, and I thought it was fantastic. So thank you, Dr. Furmick. This will be a QR code to different media or articles or something that will relate to the procedure or the practice for your own reference later. Using ultrasound, we can identify the vessels we want, and we can identify the vessels that are less desirable. On the left of the slide, you can see that the provider identifying the vein and artery by applying pressure and seeing the vein collapse easily. You can even see the pulsatility of the carotid artery. On the right side of the slide, the provider added color Doppler to differentiate between the vessels. In the PICU, when we use the neck vessels, we typically choose the right internal jugular as it's a straight shot to the right atrium in the normal anatomy. Remember, I call this the right IJ, the big daddy vessel, particularly in babies who have very large craniums. The downside of selecting the internal jugular include you need to rotate the neck to get things aligned, which can be problematic for those that need their neck immobilized, like in our trauma patients. And we have to place the patients in a Trendelenburg position to help enlarge the vessel further and avoid air embolization. So you have to take that into consideration when you're doing this kind of a line. A second possible central venous access is the subclavian vein. For these patients, we often choose the left subclavian because it allows the catheter to make an easier, more gentle turn down to the right atrium. Approaching from the right often results in an A-line or in a venous line that sits malpositioned across the innominate vein instead of going down to the RA-SVC junction as we desire. Subclavians can be useful in trauma patients who have neck braces and injured limbs, but you have to be careful because the lung can easily be entered, creating a hemo or pneumothorax. If you inadvertently hit the subclavian artery, it can also be quite difficult to apply good pressure because you got this clavicle in the way. Although subclavians can be suboptimally located when you're trying to code a patient, again, they're a quick and easy place to go after. Lastly, femoral venous access can be a nice place. Here is a POCUS image on the right. You can see the coronal view, which kind of cuts the vessels in circles, and then On the right, we have what we call the long axis, or a sagittal view, which cuts it in that whole length, so you can see the femoral vein under your probe. Truly, the femoral venous axis is an out-of-the-way piece of real estate to place a central line. It's away from the neck and chest where a lot of things are typically happening, especially in your code scenario. The clinician gets to choose left or right fem typically, and we all like choices. So unless you've had injury to one of those limbs and it's excluded, it's typically an easy place to go for. That said, in infants, the vessels in the legs tend to be quite small since the legs aren't being used as much in their infancy. Also, there can be a delay of drugs to reach the heart as compared to the other two that we talked about, which sit at that SVC-RA junction. And it's the hardest site to keep sterile of the three. One last thing about all of these temporary venous catheters, the risk of bloodstream infection from the line seems to jump significantly at day 7 to 10 after it's inserted. And so you have to think about when to remove and what accesses you have available. Another procedure which we use POCUS for is arterial access. The most common site is the radial artery, as seen here. It's typically an easy access to peripheral site, and there's collateral blood flow to the hand, typically, assuming that the ulnar artery is normal. In this POCUS video, you can see in that long axis, the needle enter the vessel, and then a catheter is introduced into the vessel. It shows the long axis is really nice because, again, you can see everything moving along that whole thing. You can be certain that you are actually in the vessel. Other sites for arterial access include the dorsalis pedis artery, the posterior tibialis artery, and if you're super desperate for some reason, the axillary artery. But again, your collateral flow can be a limiting factor unless their life is on the line. Artery catheters are low risk for infection because of the fast flow of blood, but it's also not zero. So remove your lines when you don't need them. And what makes you choose one site over another is usually ease of access, because again, there's a lot going on typically in these patients. Your presence of collateral blood supply, your ability to immobilize the area. If the kid's a big kicker, you putting an arterial line in the foot probably is not going to last very long. And if that site is injured, of course, you want to avoid accessing through an injury. Now, I can't move away from other uses of POCUS in the PICU without talking about PICs and PIVs. Peripherally inserted central catheters, or PIC lines, are a nice option in the right circumstance. PICs are inserted peripherally into a vein, just like a PIV, and are long enough to obtain central access, allowing for caustic medications that we wouldn't otherwise be able to give. Due to their insertion in the periphery, they are more comfortable and can be present longer without the rapid rise of infection risk if taken care of properly. This can allow for some patients to finish their therapies at home or avoid frequent sticks if they're going to need lots of blood work. They're started just like a regular PIV, but with POCUS, we can find multiple sites for placement in even the most difficult patients. Even the technique used to place a PIC is similar to placing the short temporary central lines. So only slight adjustments, with slight adjustments, a proficient central liner can learn to place a PIC line. So why don't we just use PICs? Well, there's several reasons, but one of the main ones are that the catheter is usually smaller in diameter than we can place with a more centrally, a central vessel. Also, the PIC line is very long, making increased resistance to pushing large volumes during resuscitation of the patient. Additionally, the setup is a bit longer because there are a few added steps, including the operator has to measure the correct length of the catheter and cut it before inserting to avoid malposition, which can increase your risk of thrombus or cardiac dysrhythmias, depending on if you're short or long. So for the emergent central access need, we reach for the short, fat, temporary central line kits. Additionally, at many hospitals, there is only a small group of people who have the skill set to place PIC lines, and they're often needed in multiple places for more than just placing PICs. As alluded to, POCUS gives the operator an advantage on even basic PIV placement. If you haven't already seen it, we readily see POCUS being used by our IV team when they can't find an adequate site to poke just by normal means and visualization. So thank heavens for POCUS and for the IV team. Now take a look at this chest x-ray. I'm no radiologist, but I think there's something not quite right on this patient's right. So I, of course, go to my radiologist read, and it says something to the effect of right-sided pulmonary opacification, atelectasis versus effusion, correlate clinically. And I'm still helpful. Now, in the past, I might have been frustrated or discouraged, but not with POCUS in my hands. In a few seconds, I can put the probe on the patient's chest and differentiate between an effusion or atelectasis. I see the image on the left, you know, the lung floating nonchalantly in a sea of fluid as the liver teases it gently by tapping. If I see that image, I know that we have an effusion and I need to place a chest tube. If I see the image on the right, I know the lung is atelectatic and not being compressed externally. That was easy, quick, and now allows me to make appropriate plan of care with minimal time spent. Now let's take a look at this patient's belly. That belly looks full and is affecting my patient's respiratory status. Is it ascites or just bowel gas? Do I need to drain it or do I need to write for some simethicone? POCUS can help. If I see floating, I'll just say if I see floating things like this in a pool of fluid, then I might need to place a drain. If I can't see much of anything, like on the right image, I know there's air in the bowel. That's because air doesn't conduct the ultrasound waves back to the probe in a discernible pattern, so it looks like my parents' old TV reception. Have you ever had a nurse call you at 3 a.m. to tell you that the patient pulled on a tube and they can't tell if it moved? Well, other potential POCUS uses in the abdomen and lungs and other places that we can employ in the PICU include quick identification of tube placements such as chest tubes and drains. An area of active research that one of my PICU fellows is studying is using POCUS to evaluate gastric feeding tube placement sensitivity and specificity compared to the abdominal x-ray with some very interesting findings. So stay tuned with that. POCUS can also be used for percutaneous placement of pheresis or dialysis lines and ECMO cannulas in some situations. And very similarly to placing a central venous catheter with POCUS, this allows us to minimize bleeding and provide emergent options without having to move an unstable patient or a coding patient through the hospital. As mentioned in Dr. Furmick's presentation, we use POCUS to get information on the cardiac squeeze or lack thereof to help quickly guide management and reevaluate if a therapy that we have initiated is actually helping improve our cardiodynamics. And lastly, I need to mention that we even use POCUS to evaluate the brain. Transcranial Doppler, an ultrasound technique, is used to evaluate flow velocities and flow symmetry in patients with brain pathology and helps guide our therapies. Additionally, modality that's being studied is looking at the optic nerve and the optic sheath through the globe of the eye with POCUS to help identify elevated intracranial pressures. More to come on that. As you can see, despite not having board content, POCUS is alive and well in the PICU with many, many applications. And our faculty here at Phoenix Children's in the PICU have been early adopters. We provide formal instruction to our fellows on its multitude of uses. We send them to Critical Care Society training courses for pediatric POCUS, and we push them to practice and gain proficiency with this emerging tool that helps us treat our seriously ill patients. PICU loves POCUS.
I will jump in here. I'm Randon Hall, one of the sports med docs here at Phoenix Children's. I think what's interesting in my situation is that I practice half of my career. So I've been here 10 years, will be in August. So you got me beat by a month. But I practiced half my career not using POCUS at all, and half of my career using POCUS. And I'd like to just make the case for why I think I'm better with an ultrasound in my hand. So just a little bit on the fellowship training. So in our fellowship, we have a certain criteria that each fellow needs to hit before they leave. So they have to scan each joint and have a protocol for each joint. So there's a knee, for example, is the best I can give, is that they need to be able to scan anterior knee, lateral knee, medial knee, posterior knee, and describe all of the key features that you would see in each of those protocols. And then we need to do that for all the different joints. And so that's a requirement for fellowships. So to even have a fellowship in sports medicine, you have to have a provider who can do ultrasound. So this is my case for why I think that I'm better with an ultrasound in my hand. And I'm going to go through each one of these. So extension of my physical exam is the first, and what I'll jump into here. And these are all images from my clinic. So as I talk about in our sports medicine lectures, in acute traumatic knee effusion, there's 5 things that cause that. So if we know that the patient has an effusion, we know it's got to be one of those 5 things. So if you're not as good with your exam, where I think it's interesting, the learners are able to use the ultrasound to say, okay, this is what the exam is. Go back, feel the patient, and be more comfortable with knowing how to do it without the ultrasound. Where in my situation, I'm pretty sure this is what it is, but I want to go back and confirm it. And so you can see here, I'll zoom in the picture. So we've got your 5 things that are possible associated with an effusion. If we can determine there's an effusion, we know we're going to get an MRI. It's really quick. So what you'll see here is we have, this is the superior aspect of the knee. You have your quadriceps tendon here, your patella here, and this large fluid accumulation is fluid within the suprapatellar pouch. So this is the long axis view, head to toe, and this is the short axis view, left to right here. So clear knee effusion, but maybe that's not a trauma, and then we have to start going down the other routes of JIA or other possibilities. So that's one thing I'll use it for, is just to enhance my physical exam. The second is confirm a suspected diagnosis. So this is a 16-year-old who was running in peak E class, had a sharp pain in their calf muscle. And then on my exam, they had pain with direct pressure to the muscle belly of the gastroc-soleus complex. And so what we'll see here is, this is the long axis, so head to toe. Here is your gastroc muscle over top, depicted by the yellow line. And then this is your soleus muscle. And you can see the nice lines of the muscle within the gastroc. And then you can see this dark fluid collection within the soleus. That confirms my suspicion that there was some type of muscular injury. And now I know it's specifically within the soleus within just a matter of moments. And this is that short axis view. So cross-sectional view, gastroc here, soleus here, and you can see those dark fibers there. And I'll be very honest, 5 years ago, it's all gray to me. Now you get over time, keep scanning, you get better and better. Okay, then the third thing is real-time feedback. So you do an exam, they have this diffuse vague pain. You want to see, do they hurt at a specific structure? So we call that sonopalpation in MSK. That means using the probe to press at the spot where the patient has pain. I can see what's under the probe and know that's where their pain is coming from. So this is a patient, 2 years of knee pain, running, cutting, jumping, no trauma, and they had pain with direct pressure at the proximal pole of the patella. The lower pole of the patella. So is that coming from the patella? Is that coming from Hoffa's fat pad? Is that coming from the quad tendon? Is there a bursitis? It's hard to say. So what we can do is we can get over that area, press with the ultrasound probe, and see where the pain is coming from. And so in the picture to the left is what a normal patella tendon looks like. And then this is what a tendinopathic tendon looks like, different from tendonitis, but a diseased tendon where you can see normal tendinous fibers on the superior aspect of the tendon, but you see this dark tendinopathic area within the tendon. It's also much larger than it's supposed to be. And then even more so, what I can do is go on the short axis or put on the Doppler and see if there's increased flow or inflammatory signs. And then I could say, okay, well, I've got tendinopathy. It hurts when I push with the probe there, and I have Doppler. It's coming from the tendon. And it's so beautiful to have the family see that right in clinic, and they feel confident that you've got the right diagnosis. So that's another feature that we'll use. And then dynamic assessment. It is quite challenging, takes a bit to get used to, because it's already hard to keep the probe on the patient with sliding with the gel. But then on top of that, if you're asking the patient to move, it can be a little bit challenging. So this patient came in with knee popping, and they said as long as they can remember when straightening and bending their knee, they felt like this clunk or shift. Now, again, I've been doing it 10 years. I can tell you if a patient says this with no trauma, it's most likely going to be a discoid meniscus. And this is what that would look like on MRI. So I'm using this to see, okay, can I dynamically show the family or myself what exactly is occurring? So in a static view, this is a lateral knee where you're in long axis, and you can see that just if you know ultrasound of the meniscus, this is much bigger than what it's supposed to be. And then let me see if I can play the video. Yeah.
You have to take off
The pointer. That's okay. Oh. Thank you. Click there. Yeah, there you go. So it's going to repeat for you here. So he's just flexing his knee, and then there's a pop. So this is the meniscus structure right here, flexing, pop. Then I could tell that the meniscus is discoid and too large, and we can clinically show the family that. Okay. Then sideline assessment. Now, this isn't an actual sideline I did, but we cover football all the time, and it's very simple to be able to look, say, is it fractured, is it not? But this was a case that kind of combines that. So a patient who had an injured collarbone playing flag football, we saw them in clinic, but imagine that you could do this on the sideline as well. And the family mentioned that there was a knot there. They had this plain x-ray, which interestingly was read as normal, and I would read it as normal, but I could tell there was a knot over the central portion of the clavicle. So that yellow line depicts where my ultrasound probe is, and then you can clearly see that there's a cortical disruption in the midshaft clavicle. So was able to show the family that as well. And then for ultrasound guided procedures, that's the main thing that we use our ultrasounds for. This is an 18-year-old who was playing basketball, set a pick and took a knee into the thigh. And I had seen him for many things over the years, and they came in about 4 weeks after the injury because he was out at college, and then he had a clearly kind of enlarged, tightened thigh and was tender to pressure, and the skin was tensed over top. And so what I wanted you guys to see was, get that pointer out of there. Sorry, I'm messing up your system here. Can you just take, I'll just leave the pointer off. Good. Really down to that spot there. There you go. So we were able to quickly scan his leg. This is the rectus femoris muscle. This is where your vastus intermedialis muscle is. And he's got this huge hematoma in the thigh. And this is painful when I'm doing that. So what I was able to do is spend way too much time making this slide, but I was able to scan 6 inches essentially and scan and stitch them all together to show that this was a huge, large effusion with hematoma with intrahematomal calcifications. And then we just had him come back later in the day and did a drainage procedure here. And so what you can see is intramuscular hematoma. We took an 18 gauge needle. After the fact, I realized that I needed a little bit longer needle. So the only 18 gauges that we have was 1.5 inch. And you can see we barely were able to get down to the fluid, but we were able to use my medical assistant to kind of milk the fluid towards the needle. And I was able to aspirate 130 mLs of fluid. And then we just did compression sleeve afterwards. And he was able to be running on the treadmill. And then you can see this is my needle trajectory here. And then the last case is just an example case of something that I think illustrates why I'm better. So we had a patient called by the athletic trainer, hey, he's on my baseball team, hurt his hip. They don't really know. And I started asking a lot of questions, and it didn't make sense that he didn't have some type of muscular injury. And he comes in limping. He has positive fader, so internal, external rotation of the hip. Log rolling his hip is positive. We got some labs because I was concerned that this was not a true MSK injury as we see them. His labs were totally normal, but we put the ultrasound over his hip, and you can see that there's this huge, large effusion there. That expedited the treatment, because normally in this setting, I'm going to get an MRI, maybe with or without contrast. In a 12-year-old, sometimes we need sedation. We were able to say, no, you need to go to the emergency room. You have a large hip effusion. We sent him to the ED. They admitted him for aspiration and washout that grew, MRSA, discharged on PO, Clinda, and gradually returned back to baseball at 2 weeks discharge. So just a little bit of what I think we can bring to the table with ultrasound in the clinic. Sometimes can feel overwhelming, but one scan at a time and get better and better.
Fantastic. I hope one thing that we're taking away, especially from a resident perspective, is that you can start to see that each field uses POCUS in their own way. And regardless of what you're going into, you're starting to see this, and some fields use it more than others, but almost every field, has some utility of point of care ultrasound. And so just getting used to ultrasound is critical. One thing that I'm going to talk about right now is a little bit of ultrasound hospitalist medicine, and then we'll go into some calls to action and ways that you guys can get involved. The main thing with hospitalist medicine, this is definitely up and coming. It's a hot topic in pediatric hospitalist medicine right now, with multiple statements by the Society of Hospital Medicine, and then new clinics every year and new procedural practices through the AAP and through the Pediatric Hospital Medicine Society. Some exams and procedures that are possible. We won't go through all of these, but I just wanted to do talk about some food for thought for the hospitalist practice. And I know residents are going through inpatient wards frequently, and so opportunities to think about. And so from the lung exam, talking about the pneumonia, pneumothorax effusion, bronchiolitis, we'll talk a little bit about that. Cardiac, we talked with Dr. Furmick, abdominal and skin. There's some interesting research on constipation. And then cellulitis and abscess is a great use of ultrasound. From a renal perspective, looking at bladder volume can be very helpful, especially for bladder caths. And then obviously looking at progression of hydronephrosis, kidney stones, UTI, pyelo, and then procedures, bladder cath, NG confirmation, like we had talked about, that's being studied in the ICU right now, and then vascular access and lumbar punctures. So a little bit of evidence for lung exams. Overall, I just wanted to point out that through pooled sensitivity and specificity, the pediatric POCUS exams, specifically for pneumothorax and pleural effusions, has good sensitivity and specificity, but you have to be looking for specific things. And so you're looking for the absence of lung sliding, you're looking for the presence of a lung point. And if you can find those things, then you can start to add that into your clinical judgment. For pneumonia, once again, both adult data and then supported by pediatric data as well. And the pediatric data is ongoing. high sensitivity and specificity, as well as a higher inter-rater agreement for normal lung and consolidation, normal lung and then consolidated lung compared to chest X-ray. And we've had there's some good randomized controlled trials. A lot of them are coming out of the emergency department, showing reductions in chest radiographs, decreased length of stay in the emergency department, as well as decreased cost. And specifically for when you're talking about use in the hospitalist division, you're talking about monitoring for complications of either bronchiolitis or viral versus bacterial, and you're trying to find, are we having effusions that are being created right now? Is this patient have a pneumothorax, and that's why they're becoming hypoxic? From a bronchiolitis perspective, identifying complications like pneumonia, also looking at possible prognostic applications is a current research topic that is ongoing at this time. This is a QR code that has a consensus statement. It's a group out of Poland, but it's a good place to go if you're just looking for updated research in lung exams, specifically for pediatric patients and point of care ultrasound. Abscess, this is, I'm sure everyone has had that case with the patient with a phlegmon and you're waiting for it to either become an abscess or get better. And so you have to wait on the ultrasound and then you reach out to surgery to see if you want to drain it or not. This is an example of a cellulitis. And so you see that cobblestoning going on. And then you have an abscess, which are a pretty clear differentiation between the two. Lumbar puncture is mixed reviews right now. Most of the research, it's mixed reviews in infants, but a lot of the research is being pointed now towards obese patients and the use of ultrasound to decrease complications. We won't spend too much time looking at it, but you can identify the anatomy, and then you use the anatomy for obese patients to mark out and determine where you're going to go, as well as determining how large of a needle you need. A couple other things talking about the constipation, specifically looking at the transrectal diameter has a strong correlation with constipation, and that's ongoing research. Bladder caths is something that can be utilized either by nursing, outpatient, inpatient, but it's far and away more common that they have much higher rates of first pass success rates with bladder cath just by looking at bladder volume. And then the other interesting facts are fluid hydration and reassessment, and specifically looking at the IVC and the aorta. That's ongoing research as well, but all exciting topics and possible uses for the future. Hospitalist groups and education for the hospitalists. There was just a conference in New York that happened on June 17th, and then the pediatric hospitalist medicine group is meeting coming up in July, and they have, I pointed out all of the different ultrasound and POCUS conference schedules that they have throughout that conference. From an outpatient medicine perspective, it's a lot of areas of research. Mostly they've done, the main topic of research is just identifying what people want. And so a general pediatric cross-sectional survey looked at over 400 outpatient pediatric physicians, and they identified skin and soft tissue, looking at cellulitis versus abscess, neck, abdomen, constipation, lung, abscess, drainage, and bladder cath, which I think all make sense. So what are we doing at Phoenix Children's? One thing, if you take anything away, if you're interested in POCUS, then this is the executive board to go through. And so everything that will be implemented at Phoenix Children's will eventually go through this board. Carrie Hall is the chair of this board, but they've created this so that there can be that oversight and that they can help bring POCUS into Phoenix Children's. But one thing that I wanted to point out is just reaching out, and once you have something that you want to bring to the table, reaching out to this board will be the final stamp of approval before it gets implemented at Phoenix Children's. This is the resident POCUS group, and I wanted to point out, so Dr. Namjoshi and Dr. Moros are both going to be chiefs next year. And then Dr. Vandela and Bernstein will be the presidents of the POCUS group. So for residents, if you are interested, you could also be put on this, and you just have to reach out to one of them. And then these are some of the attendings. There are more attendings that are interested. Dr. Furmick, who you heard today, is a fantastic connection. Dr. Mers is a med peds, and then Dr. Rocker is in the ICU. Events and projects, we've had awesome things going on this year. They've done a great job. They've put on 2 in-person POCUS sessions, and then they have they're working on a learners grant for development of a formal curriculum, as well as getting some handheld probes. And then we have a procedures and pathology coming up this Thursday and Friday, which we'll talk about. First off, though, I wanted to bring this up, and this will be, you'll have all of these 4 minutes. Is that okay?
Yeah, we're supposed to start at.
Okay. Oh, man. All right, we'll swing to the end. We'll do that. How about that? No worries. But this is the main thing. If you guys have interest, this is a QR code that you can fill out. We do have a pathology and procedure day coming up over at Valleywise this is Thursday and Friday from 1 to 4 and then 11 to 2. And we have the opportunity to actually go through and get your hands on ultrasounds, both looking at pathology and then getting access to procedures, art lines, arthrocentesis, central lines, IV access, the things that we've talked about throughout this talk today. You can actually get your hands on it and start practicing that and see if it's something that you're interested in, if you want to pursue further education and training in it. We'll swing to the end here. The resources and education. We can send all of this out, but what I want to point out is if you fill out the POCUS working group interest, if you use this QR code and sign up, then we'll put you on a working group email list, and we can send out future discussions, and then as well as resources. So you guys can all have access to that. And so if you want access to the resources that we've talked about, if you want to be part of future discussions, use this QR code. For the procedure day, if you're interested in participating and you'd like to come for an hour-long session and get some hands-on practice, you can use this QR code, and we can send this out as well. And then if you are interested in teaching and you say, I want to be more involved, I'd like to get some practice teaching and working with residents and learners, then you can use this QR code right here. I'd like to get a round of applause for all of our incredible speakers, Dr. Furmick, Willyerd, and Paul. They did a fantastic job, and I think it's exciting what POCUS is, the conversation around POCUS and what's happening right now. It's an exciting time to be a part of it, and so hopefully you guys can be a part of the future discussions. Are there any burning questions? Probably don't have time to answer them. Deal. Awesome. Thanks for coming, guys. Let us know if you have questions, and then we'll send out information as well so you guys can follow up.